First tonight, all from Cancer Treatment Centers of America, CTCA in Philadelphia, in the Juniata section. Anyone unaware, we in the new year in January of 2019 started our new partnership there on one of our satellite sites. So we are grateful to have 3 individuals with us from CTCA this evening. So we have Dr. Anthony Perry. He's the Vice Chief of Staff and Director of New Patient Intake. We have Dr. Imran Sharif, the Supportive Care Physician, and Gina Smith, Director of Oncology, Rehabilitation, and Integrative Services. So they'll all be speaking with us about making treatment decisions. We will have time at the end for questions. You can either type them in the chat box as we go along if you want to be able to keep your thought in the moment, and then we can address those questions at the end, or people can go over video on the end, but we ask you to keep yourselves muted while we have the presentation part here. So we can go ahead and get started then. Oh, can you go back one, Beth? Perfect. Go ahead, Gina. Thank you.
Can you hear me now? Kelly, you might turn off. Sorry about that.
There's some feedback there.
Sorry about that. We're dual computerizing. Sorry about that.
That's okay.
Is that better?
Yes.
Okay. All right. I'm really happy to introduce this program tonight, introduce the objectives of the program. We really want you to take away some information about how to recognize your treatment needs, how to respond. Also be knowledgeable about your diagnosis and treatment options. Knowledge, we know, is power. We also know don't do it alone. You need to include your caregiver in the process of learning and supporting your treatment decisions. We want you to learn how to build that support system and ask questions and definitely advocate for what you need from the people around you, from the medical professionals that you introduce yourself to. We want you to come away with information about caregivers and making treatment decisions, or information for your caregiver and how to make those decisions, and as well as make choices that are right for you. Next slide. One thing you need to know that I've always found interesting is the National Cancer Institute considers a person to be a survivor from the time of diagnosis. So already you are a survivor. You need to know that about you. When you're diagnosed newly, you need to educate yourself, you need to get your support, and most definitely have hope and courage. You or your loved one may have been diagnosed with cancer, but that really does not define you. That's a very, very important takeaway. Next slide. The decisions that you make, you and your medical team make about your treatment should reflect both your medical condition, but also your personal situation and your goals. Only you can bring you to the conversation when meeting your medical team. Really, you need to tell them who you are, what your life is like, who your support system is. If you don't have a support system, let them know that. That's really important when you make a decision and make a treatment plan, for them to know who's there to help you. Identify any logistical challenges. Simple as transportation. Financial, we know it's quite a burden. Costs of these treatments are significant, and the impact on your personal life is significant. So don't leave any of that out of the conversation, and always ask questions. Like, even write them down ahead of the appointment. A lot of things go through our minds as we get a diagnosis and we're meeting a new medical team or getting a second opinion, and write them down as you hear them or as they pop in your head. It's really important, and bring them. And you might not throw them all out to your medical team. You might prioritize, but it's really important for you to start to organize that first appointment. Next slide. The empowerment approach. Always state your goals, even if they're obvious. And obviously, we want to get through this disease. We want to get on the other side of it, or put it in the rearview mirror, as I like to say to patients. But making a plan is really important, but also make them achievable. Make small goals attainable. Starting with early success is really quite empowering. In life, we make a lot of goals for ourselves. We make 5-year goals, 3-year goals. You know what? Sometimes dial it into the now. you know, a couple days, minutes and minutes sometimes, something that you can set for yourself that you know you can achieve it and you've made a success. And once you get a success behind you, then the next one comes easier and the next one comes easier. So it's really important to set those goals for yourself. Shared decision making is definitely an ongoing process. Your values and goals can change over time. Your valuable treatments may change too, dependent upon your cancer. Write your treatment plan with your doctor. This is very much a collaborative process. Collaboration is really important. And you might have different healthcare professionals in your orbit through this process over time that are part of the treatment decision process, but it's also important that your goals and values really stay central to that plan. Shared decision is making a relationship based. It's very, very important for you to be part of that decision making for yourself. Okay. Next slide.
Okay, so I'm going to be talking about setting your goals. When you talk to your doctor about your treatment options, ask about the goals of the treatment and how each treatment may affect the goals that you have for your life. If you choose not to receive treatment, think about your goals for the care that you receive. Possible goals may be to live as long and or as well as possible, or make it to a special event or milestone. Let your healthcare team know about your treatment and personal goals. When setting your goals, you need to be aware of what the treatment might be and how it may affect you in different life areas. For example, thinking about your physical, emotional, sexual health, and well-being. What is the most important for you to be able to do? When thinking about family and social relationships, what's going on in the lives of others that is important to you? When thinking about work, school, and home, do you want or need to continue working? Can you adjust your schedule, responsibilities, or career goals? Are you getting the help you need for tasks at home? Next slide. When thinking about community and involvement, are you getting support you need from your community? And are you still able to stay active and involved in your community activities? In relation to personal and spiritual growth, are you taking care of yourself spiritually and emotionally? And are there any other additional life areas that are important to you? Next slide. Understanding your values. Your values are important for goal setting. Your goals and values can change over time. Ideally, your treatment would have 0 side effects, a 100% guaranteed cure, and no cost. Unfortunately, you might have to choose about what matters most to you among these options. It does depend on your cancer and its stage and treatments available, but it's important to think about what matters most to you during this time. Values may be, I value being active with my family. I value being healthy to attend maybe my appointments or going to work. I value having few side effects. I value having the best treatment available no matter what. And I value being part of a clinical trial to advance science. Next slide. I'm on helpful tips. Is that the next slide? Helpful tips.
Which it was
I have after understanding your values, helpful tips.
understanding your helpful to. Oh, okay.
Yes.
Sorry,
Okay.
I must have double clicked too fast.
No problem. No problem. That's okay. Take a little pause. So helpful tips. The cancer journey has many decision points along the way. Some helpful tips to remember along the way may include breaking the process into smaller bites, focusing on one step at a time. Locate yourself in the process. Think about your goals, your life, and your current situation. And this is a very important one. Work with your doctor to create a written treatment plan. Next slide. Understanding your diagnosis. I think we skipped a slide. I'm on understanding your diagnosis. Knowing the exact type and stage of your cancer will help you find useful information and make treatment decisions. Some tips to fully understand your diagnosis. Ask your doctor to tell you exactly what kind of cancer you have and to write it down for you. If you do not fully understand, do not hesitate to ask questions. Ask for a copy of your lab or imaging reports. Ask your doctor what they base their treatment recommendations on, and talk with your nurses, as they can also help answer questions. Talk to the other people who have had cancer, especially those with a similar diagnosis. Understanding your diagnosis. Questions to ask about your cancer diagnosis. What type of cancer do I have? What stage is my cancer, and what does that mean? Is it local, or is it's spread to another organ? What symptoms of cancer might I experience? What types of tests will I need? And where can I get a second opinion? Next slide.
So choosing your healthcare team is a very important decision. It's critical to feel comfortable and confident in the people responsible for your treatment. Know that you can always seek a second opinion or change doctors if your situation changes and you need a different level of care, but your choice is going to depend on several factors: your cancer type and stage, your personal preference. Don't remove you from that conversation. Who you connect with is really important. Unfortunately, sometimes it's insurance coverage. That's a factor that we have in our life, but also even things like logistics, transportation, distance, and cost, really important factors to consider. Next slide. All right, bear with me on this, because this is something that Dr. Sharif, Dr. Perry, and I know very well. We know all of these people. Introducing them maybe to some of you for the first time. So I'm going to go through a detailed description of who they are. Some are obvious, and some really maybe you don't know who worked behind the scenes on your behalf. Each individual is, excuse me a second. Each individual is unique. Each person's cancer is different. You are the expert in your cancer experience. Let me say that again. You are the expert in your cancer experience. It's really all revolving around you. Together, you and your healthcare team can work to get the best care for you. And knowing who is on your team is going to make it easier to efficiently manage your treatment and find the resources that you need. You may only have a few of these people on your team, and you actually may have even more, but it all depends really on a lot of things like your cancer type, your needs, your insurance, et cetera, and costs. So medical oncologist, very critical. These doctors are specially trained to diagnose and treat cancer and specialize in the use of chemotherapy and other drugs to treat cancer. Nurses, invaluable frontline workers. You will have the most direct contact with your nurses, and there's a lot of different levels of nurses and of people that specialize. Oncology nurses, our radiation therapy nurses, even our advanced oncology nurse practitioners. They have a special training caring for people with cancer. Nurse practitioners, they can prescribe medications, diagnose illnesses. Your nurses will be able to answer many of your questions, give medicine, and provide emotional support. So they're critical to your care. They're also usually in charge of implementing the treatment plan your doctor has set up for you. So it's a really important relationship that they have, the physician and the nurse. Surgeon, most of us know who they are. They're doctors that perform biopsies. They're ones that remove cells or tissues are removed from the body and examined to help with diagnosing your cancer and ultimately surgery as well, if it's necessary. A surgical oncologist is a combination of physicians. These are surgeons that specialize in treating cancer, very specific. Pathologists. These physicians will examine the biopsy, the tumor tissue, and usually are responsible for the accuracy of laboratory tests. They will provide you and your doctors with information about your tumor that will be used to determine how it will be treated. So it's very much a team. Radiologists, these doctors read and interpret x-rays, ultrasounds, CT, or what we call CAT scans, MRIs, and other imaging tests. This member of your team may also perform biopsies during special x-rays or ultrasounds. Your radiation oncologist or radiologist that specialize in the treatment of cancer using radiation. One you might not know, definitely behind the scenes, is your dosimetrist, is the person that will use radiation oncologist prescribed dose of radiation for your tumor to calculate and plan your radiation treatment. Your radiation therapist is the person who's actually going to deliver that radiation therapy. Your medical physicist is the person who will be responsible for ensuring you receive the exact dose of radiation prescribed by the radiation oncologist. Your family doctor or general practitioner is a doctor who's going to continue to provide your primary health care for you and your family. When you get cancer, you don't just have cancer, you still have all the other things that you may have brought to the table or may develop as a result, and your family doctor is really important member of the team. Your social worker is a person trained to identify social and emotional needs and provide services necessary to meet them. A social worker can help you and your family find resources to cope with cancer and its treatment. Very important person in that team. Next slide. More people on your team. On possible members of your healthcare team. There you go. Pharmacist, the doctor who will prepare and dispense your medications. She or he will be able to explain to you how your medications work. I think that's sometimes something that we don't utilize is their knowledge about how medications interact and really getting more information. You can always ask questions to your pharmacist. A psychiatrist or psychologist is a mental health specialist who can help you and your family understand, manage, and cope with feelings, thoughts, worries, and behaviors. Psychiatrists have a medical degree and have the ability to prescribe medication. They are MDs. A registered dietitian, also sometimes you'll hear a nutritionist, is a person who can help you maintain a healthy diet and get proper nutrition during your treatment and recovery. I usually like to tell my patients there's so many things that is done to you, but there's things that you definitely have control over. You have control over what you put in your body and how you use your body, and it's critical for you to stay healthy. A plastic surgeon is a doctor who specializes in cosmetic and or reconstructive surgery. A rehabilitation specialist, which is my profession, is a person who specializes in helping patients maintain or regain their ability to perform daily activities. Depending on the type of cancer you have, you may see a physical therapist, an occupational therapist, counselor, or speech therapist during and after your cancer treatment. Home health aide, an aide who can help you move around or with bathing. She or he may cook or do some household chores for you. That's when you get some home care services if they're necessary. A hospice care provider, these individuals provide specialized care to meet the needs of people who have terminal or end-stage cancer. And this type of care focuses on providing physical comfort, reducing pain, giving that emotional or spiritual support when you really need it. Our clergy, chaplains conduct religious worship and perform other spiritual functions associated with beliefs and religion. Many people find prayer and spiritual counseling can be helpful for them when they need to cope with cancer diagnosis. Next slide. Preparing for your doctor visit. Do this for every doctor appointment. New information can be shared and new treatment decisions might have to be made each time, so it's good to have it all in one place to keep track. Although recording a visit could be very helpful for you to remember key points, it is important for you to discuss this with your doctor. Just like you trust your doctor trusts you. There are also HIPAA regulations that exist to ensure your privacy is protected, so it's important to discuss how to keep these recordings safe with your doctor if you're planning on recording. So always write your questions down before you go to the doctor. Write down the answers to these questions. Sometimes we get so engaged in the face-to-face that we don't really record in some way what our answers that we're receiving. Bring a friend or family member. Sometimes a second set of ears is always helpful. But tell your doctor also about any medications you're using, including over-the-counter medications, vitamins, or supplements. And those are really important. Just because we can get these things off of our shelves in the food store, they do have an interaction. It's really important to disclose everything that you're taking to help improve your health. What you can do. Always try to stay focused on what's happening right now, rather than trying to make all the decisions at once. Be mindful, be present, always keep your ears open when you're speaking with your medical team. Ask to sit with a financial or insurance counselor at your hospital. You should have access to someone that can help you navigate some of the more difficult things that we really don't want to be bothered when we're managing with our health, but really important for ourselves, for our family members. Understand that things and how you feel about them will change. Things always change over time. Your course of care may change over time, but how also you respond to them are important to know. But also take advantage of all available resources. So the reason for this presentation is so you know all that's available to you. Ask if it's not being offered. Really important takeaway. Knowing a little bit more about who's in part of your medical team, your support system, the resources that are typically available at all hospitals. Ask if it's not offered. Absolutely.
All right. I'm Anthony Perry. I'm going to talk to you a little bit about treatment options. Next slide. So 2007, I was walking down the hall at a hospital that I had been working at previously and saw a medical oncologist who I was friends with. I had felt a lump above my collarbone several days before and went up to him and said, "Hey, can you take a look at this?" And within a few hours, I was whisked away to get a CAT scan and was found to have multiple masses in my chest and ultimately was diagnosed with Hodgkin's lymphoma. And this was 14 years ago. And so it was very important to kind of consider many of the things that are on this slide. So for instance, what are the goals of treatment? For me, obviously, young and Hodgkin's lymphoma being a relatively curable disease, the obvious goal was cure. But that's not always the case for everybody. Certainly some cancers have a better prognosis than other. And even though ideally we all want to be cured, sometimes you have to balance what the benefits of treatment are versus what the potential side effects would be. And so that's where the next kind of line goes with potential benefits. If you kind of take a look at other malignancies such as prostate cancer, today the paradigm is a little bit different than it used to be many years ago. If you take a look at the options that are available for most people today for prostate cancer, it's either a surgical intervention, a prostatectomy, there's some type of radiation that may be available, and then kind of a third category now called active surveillance. When you take a look and you say, okay, I'm not going to do surgery, I'm not going to do radiation, we're just going to watch this. And that's chosen predominantly because, especially with some prostate cancers, not all of them obviously, the trajectory of the disease is much slower. And so when you take a look at what the potential side effects of treatment are, they outweigh what the potential downside of just watching and waiting and actively, kind of surveilling the prostate cancer would be. It's important to kind of know what the potential side effects are of treatment and the reasons behind the treatment choice. So for instance, again, with Hodgkin's lymphoma, I had some options. And so the traditional combination of chemotherapy called ABVD has a very good survival rate. And there was another combination that had been recently seen in the literature that gave maybe a survival rate of maybe 1 or 2% higher than the classical ABVD. And I went to my medical oncologist and said, hey, why wouldn't I take that extra 1%? And the analogy that he gave me was that if you have a fly on the wall, you typically hit it with a fly swatter, not a nuclear bomb. And the 1 to 2% extra by this other combination would have made me miserable and potentially set me up for many other complications down the road, late and long-term side effects. For me, I had an option of whether to take radiation or not. What I know is that with radiation and the chemotherapy that I received, that the addition of radiation gave me an extra 6 or 7% as far as cure rate was concerned. But the downside was that being relatively young, that down the road in 20 or 30 years, having had radiation, I was at higher risk for other cancers like lung cancer. And so for me, the reason why I decided to take radiation was that I had 3 young kids. And so for me, being cured, that extra 6 or 7% made the difference. And so I think it's important to really know the statistics and know what's important to you, especially as it relates to your situation. Cost also plays a role, because I think, as all of you all know, when you go out on disability, if you need to, the salary that you receive is just really a fraction of what you normally make. And that has a profound implication on your ability to pay bills and otherwise. And so cost does play a role sometimes. What I see sometimes is that, and we'll talk about some of the forms of treatment, that abbreviated radiation. So for instance, there's a type of radiation called intraoperative radiation that is sometimes offered to women with breast cancer, and the breast radiation is delivered with a one-time dose at the time of surgery. And the advantage is that a woman doesn't have to go through the 6 to 8 weeks that normal radiation would be, and they can get back to work and recovery much quicker. And obviously that has an impact on their ability to get back to work and have a salary. Next slide, please. So What's the difference between guidelines and pathways? I think it's a hotly debated question because it's not so clear. And there's a subtle difference between guidelines and pathways. Next slide, please. So guidelines are basically produced by a group of experts. The most commonly used guidelines are through a group called NCCN, the National Comprehensive Cancer Network. The group of experts who have come together, reviewed all the literature with whatever specific cancer type you have, and then made recommendations based on what the data says as far as mostly outcomes. So what is the likelihood of cure? What is the likelihood of survival? And what are the potential side effects? So these guidelines are used with those things in mind, and basically it's what could be done. So there might be 3 or 4 different options that you have. They may not specifically advise one option. They're not usually taking into account the cost. Next slide. Whereas pathways are a little bit different. So pathways typically are used to reduce variability among treatments. So instead of 3 or 4 options, they may suggest that one option is better, and there might be a cost consideration of which option is better, especially in light of the fact if the cost is if the outcomes is relatively similar. You know, these pathways sometimes are reflective of insurance companies' input of wanting to reduce variability among their practitioners. So for instance, if there's 2 separate treatment options and they both have the same outcome, the question with a pathway is that typically the cost is definitely part of the consideration. So instead of what could be done, which is what guidelines are, this really depicts what should be done. And again, it also entails kind of a multidisciplinary approach. So it not only specifies the drugs, but also kind of some of the ancillary things that should be part of how you take care of a patient. Next slide, please. So again, you know, kind of similar to the last slide, the important thing to ask your clinician about your treatment options, again, is to look at what the goal is. It's extremely important. I think it's, as a clinician, the problem is that physicians are often wrong as far as the outcome. We can talk to patients about things like median survival, meaning, you know, for the most part, at what point would half the people be alive or not be alive? But the problem with really specifying that specifically is that they're generalizations and not specific. It's also important to talk again about what the benefits or risks of each treatment option would be. As I specified, I had an option to take radiation. Again, this is a common dilemma that's often discussed, especially with things like we talked about, like with prostate cancer. A man with prostate cancer who decides to go through treatment, why would you pick radiation over surgery, or why would you pick surgery over radiation? And then also, is it right to consider active surveillance? Also, it's important to kind of know what the side effects are going to be so that you can anticipate what's going to happen. So for instance, it's not uncommon for people who are getting anti-nausea medication. There are several drugs that are utilized at the time of chemotherapy, like Zofran or Aloxi. And one of the things that I think is not often known is that they can cause some side effects. So for instance, some people get constipated within the first few days. Some people get headache from that medication. So it's important to kind of be able to anticipate. And I tell people that specifically, I would know that I would need to bulk up on fiber the first few days of chemotherapy when I was receiving the Aloxi, but then make sure that if it was kind of going overboard in the opposite direction, that I would stop it several days in. Next slide, please. So I think a lot of what's difficult for patients is that you've never been through this before, or at least some of us have not been through this before. And it's hard to know what to expect. I think that for me, and for many people, that's the most difficult part, is not knowing what to expect. So how often will treatment be given and where? So many regimens can be given now orally through a pill, although some will entail the requirement to receive intravenous infusions. And so that may be once a week, that may be once every other week or every third week. It's also important to kind of know how long the treatments are going to last. So for instance, and that means two different things to me. So when I go into the infusion suite, am I going to be there for 6 hours? Am I going to be there for 3 hours? Can I anticipate what I'm going to need as far as a blanket is concerned, or some things to keep my mind busy, or that I can relax and rest? The other thing is, as far as the duration of the treatment, how many months is it going to last for? So for instance, for me, the ABVD, which I received every other week for 8 treatments, basically lasted 4 months, and then a month of radiation. But it's important to kind of be able to anticipate how long your treatment's going to be. Similarly, with breast cancer treatment, a commonly used combination called adriamycin and Cytoxan's typically given every 2 or 3 weeks, and typically 4 cycles is given, at least in the setting of where you would get it after surgery initially, and if it's for curative intent. But it's important to kind of know how to anticipate, because typically, as many of you know, as you go further with treatment, especially with chemotherapy, it gets a little tougher to endure some of the side effects. I think it's important to know what options you have available for emotional support. And so if I had to do anything over again, I probably would have done a better job as far as emotional support is concerned, because I had much more anxiety than I had anticipated. I'm not normally an anxious person, but I had what's called anticipatory nausea. So the minute that I walked into the infusion suite, I was nauseous and actually would vomit before a drop of chemotherapy would go into my vein. And I think prepping myself, probably going through cognitive behavioral therapy and knowing how to manage the anxiety that I had, and maybe even a little bit of pharmacologic treatment beforehand, probably would have done me a world of good. Next slide, please. So we're going to talk a little bit about treatment options, and you can see on the slide what those are. Next slide. So chemotherapy is considered systemic treatment, meaning that it typically hits from head to toe. There are some things that do not cross what's called the blood-brain barrier. So there are drugs that don't cross over to the brain, which is an important point, because some cancers that travel to the brain would not otherwise be treated in that capacity. Most chemotherapies work in a number of different ways. It's amazing, kind of some of the sources of which chemotherapy have come through. So, the Pacific yew tree is a tree in which Taxol, a common chemotherapeutic agent, is derived from. We know that there are also treatments that are derived from sea animals. Yondalis is derived from the sea squirt, so it's pretty neat where these things come from. But many of them really affect the duplication of DNA, because as you may know, cancer is really defined as the unregulated division of cells, whereas normally we have kind of some supervision of how things are dividing, whereas with cancer it's unregulated. And so many of the treatment options that are chemotherapy based really affect the signaling pathway that tells cells to divide. And or they also can affect kind of the normal mechanism by which we duplicate our DNA for the next cell, slow that down or suspend it or interfere with that. Chemotherapy can be given in the form of intravenously or a pill, or even directly applied to the tumor. So for instance, some people who have, let's say, liver cancer can sometimes get something called chemoembolization, where through an artery in the groin or in the arm, they can kind of go up directly and infuse chemotherapy directly into the tumor. Next slide. So radiation therapy, there's a number of different types of radiation. So external beam means sitting on a table typically, it goes directly to the area, but also can hit kind of everything in its way. It's something that I talk about with men who are undergoing prostate cancer treatment, because external beam radiation typically goes through certain parts of your body, like the bowels and the bladder, until it gets to the prostate and focuses the energy there. And so certainly with radiation going through that area, it can also have some side effects, including kind of urinary issues, as well as diarrhea as well, or irritation of the rectum. There's newer types of radiation. So there's stereotactic, meaning that it's pinpointed. There's proton, whose proton therapy, which is even the most specific, but really the utilization of proton therapy is useful in things where you really want to focus on getting the radiation to kill the tumor cells exactly where you want it to be. So for instance, spinal cord tumors or the brain may be two places where proton therapy is especially important, because you want to avoid the fallout of potentially hitting other areas of the spinal cord. Similarly, there may be a reason why you don't want proton therapy. So for instance, with my radiation, I got photon, which is typically the standard of external beam radiation. And the reason is that you want to kind of be able to get a little bit of a shield around the area that you're pinpointing with the radiation, so that it gives you a little bit extra coverage. Internal radiation is now used, so some men get radioactive seeds implanted into their prostate glands. Intraoperative radiation, I think we spoke about a little bit earlier. So for a selected number of women with breast cancer, again, instead of going through 6 weeks of radiation therapy, they can sometimes at the time of surgery get a one-time dose while kind of the tumor is exposed, or you remove the tumor, and the bed of where the tumor was gets the focus of the radiation. And so because you don't have to go through skin or soft tissue, the amount of radiation that can be delivered can be much, much less, and in a one-time deal, rather than the extended 6 weeks that we talked about. Next slide. Surgery. So surgery, there's many different types, as you know. So I think the trend today is to go more towards laparoscopic and minimally invasive surgeries, including robotic surgery, so that you can spare vital structures. It also helps with recovery if you can do things laparoscopically as well. Surgery may be the most effective way to get rid of a tumor. Certainly there are some circumstances in which you can get what's called definitive radiation to kill the tumor and not need surgery. But in most cancers, part of the intent to cure involves surgery, because it's just the best way to get rid of tumor cells and be rid of it. It also helps with staging. So again, with breast cancer especially, or with colorectal cancer, typically lymph nodes are removed. And most staging involves the size of the tumor, how many layers of a wall that it has penetrated, whether it's through your bladder or colon, and then how many lymph nodes are involved. And so debulking is a term that's used to try to get as much of the tumor out of the place that you're trying to remove the tumor from. So for instance, there are some circumstances in which, especially with certain types of cancer like colorectal cancer or gastric cancer, where it can spread to the covering of the abdomen called the peritoneum. And so it's not uncommon that a procedure called debulking is done, where they try to what's called cytoreduce, which means try to get as many cells out of the area as possible so that the chemo can have a better chance at affecting things in a positive way. And then reconstruction, obviously you're aware of trying to restore that body part to at least cosmetically in some way, the way that it was beforehand. Next slide. So targeted therapy. So targeted therapy is, as we talked about, chemotherapy kind of hits from head to toe, good cells and bad. And so it doesn't necessarily target just cancer cells. But targeted therapy isn't new. For instance, when we talk about breast cancer treatment, it's not uncommon that proteins on the surface of the cell are targeted, specifically for estrogen receptors and progesterone receptors. So those therapies, like tamoxifen or aromatase inhibitors like letrozole or Femara, are commonly used anti-estrogen and progesterone drugs. They've been around for quite some time. Additionally, there's a protein on the surface of breast cancer cells in some women called HER2, and that can be targeted by specific treatments called Herceptin or Perjeta that attack specifically that protein. Now, targeted therapy today also means some of the wave of what's called next generation sequencing, which means looking at the tumor specifically, looking at the genetics within the tumor to try to figure out, was there a driver that caused this cancer to occur? So for instance, there's a number of genes that we see that affect cell division within patients. And if there's a mutation, it can also affect your ability to kind of control the abnormal copying of DNA, which can lead to, unfortunately, the cancer. So normally in the process of cells dividing, we copy our own DNA, but sometimes it screws up. And so some of the screw-ups are typically taken care of by a gene that's within the DNA. But sometimes if you have a mutation in the gene, it doesn't really do the effective job of treating that and preventing the cancer. So unfortunately, not all types can be treated with targeted therapy and do require chemotherapy. It all really comes down to the studies that show benefit. So ideally, obviously, everybody would want a targeted therapy, but the key is that it doesn't always pan out the way that you think. Because even though that there might be a mutation that can lead to a targeted therapy, there may be 5 or 6 or 7 genetic mutations that you identify through this next generation sequencing, but you don't really know which is the one that was the driver of the cancer. And so that's why it's important to know through studies and potentially clinical studies, people with specific gene mutations, the benefit as far as longevity and survival. Next slide. And I'm sure all of you have heard a lot about immunotherapy today. So normally, cancer cells evade our own immune system. We have parts of our immune system, natural killer cells, whose job is to kill those foreign cells. And so unfortunately, cancer cells can hide from our immune system. Many of these new immune system or immunotherapy drugs, which I'm sure all of you see on TV today, we're inundated and bombarded by a number of those advertisements. But what basically they do is uncover the defense system, or it uncovers the cancer cell that's hiding so that your own defense system can identify, latch onto that cancer cell, and then use its own natural defenses to destroy that cancer cell. And this is such an exciting, kind of option today, especially because generally speaking, the severity of side effects is less with immunotherapy for the most part. The number of grade 3 and 4 kind of side effects is far less than when compared to chemotherapy. Today, we're even combining chemotherapy with immunotherapy because sometimes if you can kind of target the cancer in a multitude of ways, you can have a beneficial effect. Next slide.
Okay, thank you, Anthony. Dr. Sharif, back again, palliative care physician. So I'll be talking about palliative and supportive care, and often these terms are synonymous. And we've actually shifted from palliative to supportive care, as often people may have felt that palliative has a negative connotation or association with hospice. However, in the research, especially in the earlier part of the 2010s, palliative care is shown to help patients live longer and a better quality of life. And so often we also use the term supportive care. Palliative care is provided by a team of healthcare professionals who work together with the patient's other doctors to provide an extra layer of support. It focuses on providing patients with relief from symptoms, pain, and stress of a cancer diagnosis, and often can start at diagnosis. The goal is to improve quality of life for the patient and attends to the needs of family and caregivers. And palliative care is not the same as hospice, as patients can receive treatment while also receiving palliative care. Whereas in hospice care, patients are actually at a point where they've decided not to continue with hospice, they have decided not to continue with cancer therapy or treatment, or their body can no longer tolerate treatment, or the recommendation from their treatment team is to consider more focusing on symptom management and additional support with a hospice team, which includes a nurse, a home health aide, another physician, a chaplain, and a social worker, and also medications and equipment. I often say that in palliative care, we're your pals, and hospice can bring you peace. Next slide. Next slide. Okay, great. Questions to ask during treatment. The symptoms and side effects that are affecting me the most are, well, as Dr. Perry went through quite a few treatments, some side effects may include, or symptoms, pain, nausea, tingling in the fingers and toes. These symptoms may interfere with a patient and their life in ways where they may feel more fatigued, have trouble sleeping, they may affect their appetite. What can we do to manage these symptoms? So often it may be discussing with the oncology team regarding medications to manage these side effects. It may include also a dose reduction on the cancer therapies. And also looking into other complementary therapies or supportive palliative care help manage patient symptoms and side effects. And often asking your treatment team, can you refer me to a palliative care specialist? I think one thing to also note is that side effects and symptoms aren't only physical, they can be psychological, social, and spiritual, referring back to the earlier slide that I talked about regarding life areas and your cancer therapy regimen. Next slide. Coping with side effects. So you may have side effects from your treatment. It's important and I think a good idea to write down your side effects. Write down the time they occurred, severity, and how it makes you feel. Write down how these side effects impact your life. Note what things you're doing when these side effects occur. Are they affecting certain activities or certain times of the day that you're noticing these symptoms? And make sure you talk to your doctor about the side effects as well as your caregivers. Next slide. So important tools to help with common concerns. Important documents for everyone. A living will or advance directive lets your doctor know what kind of medical care you want if you cannot speak for yourself. And a durable power of attorney is a document that names a person who will make health decisions for you if you are unable to make them yourself. This person is called a healthcare proxy and does not need to be an attorney. And so I often ask patients, sometimes on my initial visit with them or subsequent visits, do they have these documents in place? Would they like to learn more information about these documents? And also it enters the conversation about who their additional caregivers and support system is and helping them make healthcare decisions. Next slide. Further terms are a financial power of attorney is naming a person who will make financial decisions for their home and medical care in the event you're unable to do so yourself. A do not resuscitate or DNR or allow natural death, abbreviated A&D, or do not attempt resuscitation, a DNAR, is an order that for your doctor if you would not like heroic measures to be taken in the event of a cardiac or respiratory arrest. Heroic measures means having your heart shocked or having chest compressions or being placed on a breathing machine. In 2005, I know the terms DNR or A&D or DNAR may seem similar, but in 2005, actually, the American Heart Association recommended actually to have a shift from do not resuscitate to allow natural death or do not attempt resuscitation. As when you talk about these terms, especially when patients are near end of life and you have organs that are not working properly, either from cancer or another chronic medical condition, for example, severe pulmonary disease, COPD, or severe heart disease, or chronic kidney disease. Actual resuscitation and CPR and these medical interventions might not provide success for the patient or to be able to come back to that if they had a cardiac arrest or respiratory arrest in order to a quality of life that they would want to look forward to. And so when you look at these terms and you review them, basically when you look at DNR, it may give the misconception that the resuscitation may be more likely to actually have a successful response or successful rate when indeed it may not. And allow and do not attempt resuscitation actually is more clear language saying that we could attempt resuscitation, but it's not going to give you it's not going to give you a better quality of life. I often like the term allow natural death because that's sort of probably the most clear language and giving the patient the most autonomy and basically saying that in a situation where medical interventions aren't going to give you a better quality of life, you can allow it just to be have a natural, peaceful death and have your symptoms managed. A will states who will receive your money and belongings and who will be responsible for your children in the absence of another parent. Next slide. Caregiving. So in palliative care, we're often asking patients, and I often do it on day one, who their support system is and who their caregivers are. And I often challenge patients to have more than one caregiver in case, that caregiver that they come with may have additional obligations. And so as a caregiver, you may feel rushed to make a decision about your loved one's treatment. And it is important to remember to slow down and think things through. This will give you a greater sense of control and provide a calm presence. And it's always important to take time to ask questions, think through the steps, and partner with the medical team to develop a treatment plan for your loved one. Next slide. It is important that you take notes for yourself and your loved one, as oftentimes as you're going to see a lot of specialists during the day or the oncology team, your loved one may be on some medications that may make them tired, fatigued, or their illness may make them tired as well. So it's important that you also take notes. And you may see a lot of people and get confused on who said what. So I think taking notes is a great idea. Compare notes with one another after each appointment to discuss what each other heard. You may interpret things differently or miss something. I often see this a lot of times when I'm seeing patients and caregivers. And I often review with patients and caregivers what they just went over in the previous appointment with their oncologist or another specialist. And it creates a definitely big aha moment when something was just missed and I reviewed the notes, and it's an eye-opening experience, and they're very appreciative. Make time to take care for yourself as well as a caregiver, because you also have your own obligations, and ask for help when you need it. Dealing with a cancer diagnosis is hard on everyone, and as a caregiver, you might be overwhelmed, scared, upset, and having many emotions, and you are allowed to feel these emotions. Next slide. Taking the next steps, be selective as to where you find your information, and use proven, reliable sources. Benefit from the experience of others, but remember that your path is unique. And choose a doctor you can trust and feel comfortable and openly communicate with. I think throughout the whole process, when you're going through a cancer diagnosis and looking over cancer therapy options, I think one thing is to remember to retain your autonomy and having as much information provided to you from the experts. I think Dr. Perry's example is a great one, because it definitely, he definitely shared with you, the options that were available, and his provider enabled him to make an informed decision on what is best for his situation and his quality of life. Next slide.
Okay, so this is just going over some of the resources available to you during your treatment journey and cancer journey through Cancer Support Community. So we have our helpline, and the phone number is listed there. It's staffed by professional counselors available to assist you Monday through Friday, 9 a.m. to 9 p.m. And actually during the coronavirus pandemic, they extended to have weekend hours as well, which is Saturday, Sunday, 9 to 5. There's also the Cancer Registry Experience, which is where they collect, analyze, and share information for patients and families. We also have Open to Options, which is a nice program where we have trained specialists to help you prepare your specific questions and concerns. This can be helpful prior to appointments you might be particularly stressed about, or ones where you feel you might need to make particular decisions. and the Frankly Speaking About Cancer, which is what this program is through. And that is lots of digital and through print, in-person programs, and different educational things that can be helpful during cancer. A little more about the Cancer Registry. This is a research survey to identify and understand the emotional and social needs related to cancer. So as we touched on throughout this, your treatment experience is not just going to be about physically what's going on, but also emotionally and socially. So this collects all that information to inform medical professionals about patient needs that they can improve the care they're providing.